Hey everybody. We are going to go ahead and it is working today. Okay, good deal. For some reason my webcam hasn't working. Not that you really care whether you see me as long as you get the information that you need, right? So, I'm going to get started on picking up on the lecture from where we left off on pharmacology. So we're going to talk a little bit more about pharmacodynamics. That is the receptor site. That's where the proteins connect in the cell. So you have these receptors in your cell that basically are open, waiting for something to come in to tell it to activate and to do something. And so that's what happens when the receptor site is activated. It's activated by chemicals, either medicines or chemicals within the body. And an example of that is our body makes endorphins when we do things that are really strenuous, really scary, or things that overexert us and that can cause us a lot of pain. Our body makes its own endorphins. Endorphins help control pain within the body. So people who are like marathon runners have crazy endorphins, and that's how once they get past that first 30 minutes of running, they can continue to go on, is because the body releases those endorphins and it inhibits any kind of pain, or helps to inhibit pain. Those same receptor sites, when someone takes a pain medication like hydrocodone, Tylenol with codeine, any of those kind of medications that are opioid related, that will also bind in those same receptor sites to help block the nervous system from making you have pain. So that's when the receptor site is activated. And I'm sorry, I do this every time and I forget to click on the present button. Now let me get to where we were. Oops, there we go. Okay, so when the medication binds to the receptor, it does a few different things. The channels permit the passage of ions in the cell wall that can open or close. So basically, it can open the receptor up. An example would be, or it can close it. So like I said, if you take a pain medication, that closes that receptor to prevent neurotransmitters from dumping and causing or continuing for you to feel certain types of pain. Where it could open it would be when you take a blood pressure medication that's a vasodilator. What it would do is it would open up the channels to relax the blood vessels that have been constricted so that the blood pressure will lower. Those would be a couple of reasons that are a couple of ways that medications can open and close different kinds of channels in the body. The body sends out a biochemical receptor that it tells the body, it also activates another portion of the body. So like I said, that's an example. Once that channel is closed, then it sends that message through the rest of the body saying, okay, we don't feel pain, or okay, the rest of the vessels in the body need to relax and to dilate so that there's better blood pressure. It can change the normal function of cells. It can increase or decrease their metabolism. It can change the number of cells that are doing a certain thing. Also, it can inhibit certain cellular functions. So it can inhibit some chemicals, can inhibit protein synthesis or things like that. Medications are exogenous chemicals. That means they come from outside of the body, and they bind to specific receptors to make the body do specific things. So medications, newer medications have an even narrower target. An example of this would be for cancer treatment. So for years, many years in the beginning of cancer treatment, what we gave people, it actually killed off every rapidly growing cell, which meant red blood cells, white blood cells, hair, nails. It softened the nails, hair follicles, hair fell out. So those really rapidly reproducing cells, it would kill all of them off. It couldn't just kill the cancer cell. Now we have cancer treatment that targets specific cells. only. And so we have less side effect, like less anemia. We have less GI symptoms because it doesn't kill off the good cells in the gut like it did before. So those newer cells, those newer medications target specific cells. Things that maybe a larger, like I said, those larger spectrum treatments, they would just kill off those rapidly growing cells. So that's an example of how medications do a specific target a specific type of cell, but as we have improved the process of understanding the genetics of the genetics of humans, we have been able to target specific cells or specific markers on cells even. There are two types of medication that affect cellular activity by binding to the receptors. Those are agonists or antagonists. So an agonist initiates or alters cellular function. You'll need to know this particular piece of pharmacodynamics for sure. There are two types of medications. There are agonists and antagonists. Agonists initiate an activity or alter the activity of a cell. Antagonists prevent either chemical reactions, or they prevent the cell from receiving information, or they prevent cellular activity. So an agonist kind of improves or alters the state so it runs better. An antagonist slows it down or stops or changes the ability for a cell to act. And so this is the principles of pharmacodynamics. So you're looking at a natural chemical there on the far left that is in the body. It fits into that cellular or that receptor site, and it makes things happen. With an agonist, you know, you're just having normal cellular activity. With an agonist, when you have that chemical put in there, floating around with your own body's natural chemicals, say for example, you take a synthetic thyroid hormone, it'll fit into the receptor sites, and it actually improves your metabolism and improves the thyroid function. So that would be an agonistic drug, would be like a thyroid replacement hormone. And then on the antagonistic end, which would be there on the right, you have your natural chemicals, which would be like the inflammation process, or the chemicals that let the neurotransmitters that let the body know that you have pain. When you take that pain medication, it fits into those receptor sites to prevent those neurotransmitters from letting your brain know you're hurting. So it blocks that cellular activity. So hopefully that makes agonist and antagonist, that image makes it a little easier to understand. Antagonist medications, they have the ability to bind with particular sites, just like you saw. There is a threshold level, and that's like an amount of medication or amount of that particular chemical that has to be available in the body to initiate or alter the cellular activity. So that's why if you have, say you have a really bad infection and they're going to give you an antibiotic. They're going to give you, it's one of those reasons we learned medical math. Say they're going to give you vancomycin. Vancomycin has to have a specific level in the body for the whole a 24-hour period for it to continually break down that bacterial wall. So there's a constant level in the body so that the body's infection control system acts appropriately. It helps speed it up so that it can fight off that infection. If you get to a certain level that's below that, then that ability to fight off that really serious infection decreases, and the bacteria can increase. The growth of the bacteria can increase. So there's a specific level. There's a minimum and a maximum level, and once you reach that maximum level, so when we did things that were like, when we did problems that were milligrams per kilogram. You do that so that you get a threshold window, because maybe the maximum amount that a patient can receive for the day is 2 grams of something. But they can't take it all at once. But over 2 grams would be a toxic level. But at 2 grams or between 1,500 and 2 grams, you're at a maximum capacity that the cell can handle, the change in the activity, and it can continue to function at maximum or at an elevated capacity to fight off an infection. So that means that when it gets to that maximum capacity, all the receptor sites are being occupied and everything's running like it's got a full tank of gas. When you get below that, as the medication starts to be, as those receptor sites utilize all that medication in that receptor site, then it'll slow down until more is available. We're looking at the ability of the medication to bind with a particular receptor site. So we're looking at important receptor sites within the body that bind with medication. Alpha-1 sites, those are vasoconstrictors in your arteries and veins. Alpha-2, those are related to your insulin and your pancreas, your insulin, your glucagon, epinephrine, norepinephrine. Those are your alpha-2 sites. Your beta-1 and beta-2. So beta blockers or the beta-1 sites have to do with your heart and cardiac output. If you're having any kind of heart attack or anything like that, lots of times they will the beta-1. You'll give a beta blocker to help decrease the amount of cardiac damage. Also, beta-1 blockers will make the body retain fluid, urine, because they release something called renin. Renin is a chemical that the adrenal gland releases, so that basically you hold on to fluid. It makes you retain fluid. Beta-2 blockers, beta-2 cells are in the bronchus or in the lungs. They're found in the pancreas. They're found in the uterine lining. Beta-2 blockers are part of what we help relax the uterus once we have finished contracting, either after giving birth or after a menstrual cycle. And also beta-2 blockers also have artery dilation in major organs like your kidneys, your liver, places like that. Dopamine or dopaminergic drugs, they are vasodilators for the kidneys and the mesenteric arteries. That would be in the abdomen. And we give that a lot when people have gone into shock. We give dopamine. Then we have nicotinic, and those are your acetylcholine inhibitors. They allow acetylcholine to stimulate muscle contraction, so they inhibit or they either increase or inhibit activity at the neuromuscular junction in the synaptic clefts. And then you have ones that are specific to the heart. So just know that we have alpha and beta. They're the ones we deal with most with medications in the clinic setting. Sometimes we do stuff with muscular and other cardiac drugs, but those are the things we deal with most often. The threshold level, which is the initiation of the altered cellular level, begins. It increases the concentration, it increases the activity, and when all the sites are occupied, once again, maximum capacity is reached. Okay, so here's what potency. Potency is the concentration of the medication that's required to get cellular response. So potency of a medication is the percentage of the medication that the body actually gets. If you get something IV, you get all of that medication. If you get something in the muscle or in the fat tissue, you get not quite 100% of it, but you get a larger portion. When you take something by mouth, you get less of that because it is broken down through the digestive process. So depending on what's going on, the amount of potency that you get is determined basically on how you take it, whether it's IV, IM, or PO. The efficacy or the effectiveness of it is the ability for the body to actually utilize it. And is it a therapeutic way or is it non-therapeutic? So if I give you, say you went into the doctor's office and you had a cold, but you have high blood pressure, and I told you to just go get something with Sudafed. To go get some Sudafed, that would clear out your nose. Well, it will work effectively on your sinuses, but it'll also increase your blood pressure. So even though it's therapeutic for one part of the body, it is not therapeutic for the other. So we have to think about the effectiveness of the medication overall. We want to make sure that when we give a medication for one thing, it's not impacting another part of the body. And that's why it's so important that we understand the different ways medications interact and how they interact within the body, what systems they affect initially, and then what systems they can affect secondarily. If you don't understand that and patients go home and take these medications, they can have adverse events or adverse reactions that are actually worse than what they came in for to begin with. So it's really important that we understand anatomy as a medical assistant, as a medical professional, period, so that we can understand how these medications work independently and along with other medications. One of the things I always like to tell everybody is 75% of all of the medications that are sold in the entire world are sold in America. So that means that Americans take a lot of medications, and they take a lot. If you take more than 3 medications, it's considered polypharmacy, which means multiple medications. You will have, as a medical professional, you'll have patients taking 10, 15, 20, 30, 40 different medications a day. And so we have to know when there are interactions or possible adverse reactions to combinations of medications. Dose response, dose response is what happens once the body takes it. Once you take it in, how long does it take it to reach that threshold and start to activate? It slowly increases in concentration in the blood. It kind of levels off, and then it slopes back down. So that's how the body responds, and that's based on how the body holds on to it in the receptors. There are some receptor sites. Morphine is a medication that when you give it, the body really rapidly burns that up. So morphine can be given every hour. Where if you give someone a medication like Demerol, which they don't give Demerol much anymore. But if you give Demerol, you give it less often because it actually holds on to those receptor sites longer. It doesn't get utilized or used up quite as fast. So it wouldn't be given as quickly. It wouldn't be given as often because the body won't burn it up and you'll still have a therapeutic level for longer. Antagonistic medications, they prevent cellular response to agonistic chemicals. They're the ones that prevent the natural chemicals from actually binding in the sites and making things happen within the cell. They treat harmful agonistic effects of medication. So sometimes an antagonistic medication may be that you're allergic to, maybe you're allergic to bees, and you get stung, and you take an EpiPen. You use an EpiPen, and they give you Benadryl, and those are antagonistic medications because they stop the histamine response in the body. So that would be an example of how that antagonistic medication would work in the body. There are competitive antagonists, and they temporarily bind in those receptor sites to stop things from happening within the cell. And so they compete for those sites, so those receptor sites. So they may not fill every receptor site and block off all activity. It just may slow down the process. Non-competitive antagonists, they permanently bind with this receptor site and prevent activation of that chemical altogether. It's continued until a new receptor site or cells are created. It cannot overcome or increase by increased dose of the. So it doesn't. If you increase the dose of the medication that it's inhibiting, it won't change that slowed down effect simply because it doesn't have a new cell for it to go in. It binds to that receptor site permanently. Partial antagonistic chemicals bind to the receptor site, but they don't initiate or they don't change cellular activity very much. They lower the effectiveness of other chemicals they lower the effectiveness of other medications. Medications can alter cellular function without interacting with receptors. So that would be like, we talked a little bit about anti-infectives like antibiotics, lipids, water, and possibly other toxic symptoms. Antimicrobials, those are agents that target bacteria or fungus. That would be your antibiotics, antifungals, things like penicillin. Acyclovir is an antiviral. They are chilting agents, and they bind with heavy metals like sodium bicarbonate to they're bound with them so that they can be utilized better in the body. Diuretics are another medication that alter the mechanism of the drug interaction, so they create osmotic changes. Diuretics make the body get rid of fluid and electrolytes, so they alter the level of potassium and sodium and chloride in the body. And so we have to be very careful when we give these diuretics to make sure that if it's a potassium wasting medication, that the patient's on a potassium supplement possibly as well. Lasix, or furosemide, hydrochlorothiazide. Those are some medications that are potassium wasting, and so most of the time the patient needs to be on a supplement so that their potassium level doesn't get so low that it causes cardiac issues. Their chloride can get low as well. So we have to be sure that we understand how those kind of medications, even though we're pulling off that excess fluid, it affects other parts of the body. Factors affecting the response to a medication, the choice of the medication, which is like how is it administered? Is it given IV? Is it a generic? Is it a name brand? The dose, the amount, the route. Is it given PO? Is it given IM? Is it given every 6 hours, 12 hours, once a day? And how is it administered? How are we monitoring it? We have to monitor the way a lot of medications. We have to monitor a lot of medications. Diuretics are one of them. Certain antibiotics. Certain lithium is one of those we have to monitor very closely. There's a lot of things that we have to monitor the level to make sure that it's being effective. Some of the things we have to, when it talks about manner of administration. So if someone takes a thyroid pill, if they take a medication for their thyroid and they take it and then they eat or drink something before or after they take it, it doesn't work. It has to be taken on an empty stomach, and you can't eat or drink anything for at least 30 minutes after you take a thyroid medicine. So that would be that manner of administration. Does it need to be taken with food? Does it need to be taken on an empty stomach? You just have to be sure that you're aware and that you can tell a patient, okay, well, when you take this, be sure that you take it on an empty stomach and you just with a little bit of water, and you wait 30 minutes before you eat or drink anything. Another type of medication that fall into that category would be medications that affect the acid balance in the stomach. Things like Ranitidine and proton pump inhibitors also have to be taken on an empty stomach 30 minutes before you eat, or they're not effective. Another thing that affects how the body responds to a medication definitely is age. The very young and the very old, medications affect them in a much different manner. As we age, our body is not able to get rid of things as well as it used to because our kidney or our liver, our circulatory system doesn't work the way that it did before. So there may be a longer half-life, or we may retain that medication in longer. A younger person's body also, due to a low amount of body fat or other disease processes, they may not be able to process the medication, or they may process it faster and need it more often. So we have to take age into consideration. We may have to titrate medication for kids, like I was saying, for the kids and for kiddos and for elderly, because of the way their body a child's liver, kidneys, heart, they're not completely developed. And in someone that's a geriatric patient, their body isn't processing it as well anymore because things start to wear out. So we have to remember that. Weight-based medication dosing. So you guys did milligrams per kilogram, a whole lot. There's some advantages to that because it gives you medication proportion to the patient size. Sometimes manufacturers already calculate the dose. An example of that would be ibuprofen. Ibuprofen, on the back of the bottle, it says one for an adult, 200 milligram tabs every day or every 6 hours. Well, for a physician, they can prescribe that at 10 milligrams a kilogram. That's a very different dose than 400 milligrams for an adult every 6 hours. So sometimes the manufacturer's dose and what the doctor can prescribe are very different. And we have to be able to and understand that we have to calculate doses for age and for weight and for medications all the time, which is one of the reasons that it's so important that you understood the medical math. Also, there are some limitations. Sometimes we need to be able to convert that weight from pounds to kilograms quickly. If you're not a good judge of character, or you don't have a scale, then it can be you could give way too much or not enough. It doesn't consider alterations in distribution of or the way that you distribute the body. Manages that medication internally. If we just do it based on milligrams per kilogram and not factor in body weight, not factor in age, or factor in disease processes, then it may actually cause more problems than it does harm. So depending on the medication, the doctor we have to think about what we're administering. Also, either if we're really warm or really cold, it may affect the way that we break medication down. If we are running a fever, or someone is out in the heat, they may metabolize it much faster than if they are out in the cold because of the change in the cardiac function and the change in the renal function. Genetic factors. So we have to be really careful about administering medication to patients that have genetic disorders. People with pulmonary hypertension, people with sickle cell, people with multiple genetic disorders. If someone has a genetic disorder and the doctor prescribes something, you just want to make sure that they've been aware. Also, be sure you're doing your histories. When a patient comes in, a new patient or any patient comes in, you want to make sure that you're clarifying and you are updating their family history, their individual history as every visit, because sometimes they'll forget to tell you things and at the next visit they'll tell you again. So just because you saw a patient for the first time and asked them tons and tons of questions on the first visit, you ask them about their parents, their grandparents, all of that. That doesn't mean you don't need to ask them again. You need to update their history every time they come in, because you have to have that source of information for the doctor so that he can make the best choices for medications for them. Pregnancy is another huge thing that we have to think about when a patient is on a medication. There's a pregnancy category that we'll discuss a little bit later, that whether a medication is safe for someone who's pregnant. If they're category X for pregnancy, they absolutely cannot take the medication. Now, there are some medications that they have to take or can take, and due to the change in the body, because you have increased cardiac output and increased fluid volume in the body, because you have the baby's volume as well, we have to think about that. Also, when you're pregnant, you get a little anemic because you are sharing that hemoglobin and hematocrit with the baby. So you're circulating oxygen in and out and carbon dioxide, not just for yourself, but for the baby. You do get a little more fluid volume, but sometimes you still, people who went during pregnancy will still be anemic. So we have to be aware of that. Our ability to breathe changes during pregnancy, especially the last trimester, our tidal volume, because we are carrying a large human in the abdomen. We have to think about the way that we can breathe in and out. and what is reserved. If you've known anybody who's been pregnant that last 3 or 4 weeks, they can barely walk up the stairs without getting really short of breath because they have that extra person and extra body weight they're carrying. Also, there is an increase in constipation with pregnant people. Often, their GI motility, the movement in their intestine, it slows down. Also, the ability for urinary, you have increased urination, you have increased renal blood flow because you're filtering stuff out for you and the baby. So you have to think about that, so that maybe that certain medications, they may be getting rid of them faster than they were before. Also, hormones change during pregnancy. So the endocrine glands undergo different levels of hormone changes. So we have to remember there are hormonal changes as well during pregnancy. This talks about the categories that I talked about, the changes in effectiveness, absorption, other things to consider related to the fetus. So if something, and know this chart on the right. So if the pregnancy category. So if it's a category A, that means that that there's no risk to the baby. It's okay to take it. Category B means that the animal reproduction studies have not shown that there's fetal risk, but there have been no human studies. Category C says that there have been some adverse effects, so it's probably not a good. There's been effects in animals, but no evident effects in animals, but no studies on pregnant women. Category D, it means that it says that there have been positive effects on human fetus, so that you should not, they most likely should not, unless it's a life-threatening situation, they probably shouldn't take category D. Category X shows that basically there is risk to the fetus, there is definite risk to the fetus, and should not be administered during pregnancy. Psychosocial factors. Pain, anxiety, and discomfort vary among everyone. Pain is relative to the person. Pain is subjective. Anxiety is subjective. Discomfort, those are subjective things. They are not objective. You can't see or touch pain. You can look for nonverbal cues. You can ask them to rate their pain on a scale of 0 to 10. You can look and see if they're grimacing or if they're hollering. And you can, and sometimes you can, or they'll be very stoic and very tense, and maybe they're in pain. But sometimes those kind of things are very difficult to tell. So, sometimes we have to be able to take our patient at their word about pain. Let me see where we are on time, guys. Hang on 1 second. Okay, we still have a few more minutes of lecture left, and then I want you guys to work some more on your top 20 drugs. You guys will have a test over that next Friday, so be sure you're working on learning those 29 drugs A and B. Types of medication response. There are therapeutic responses, and that's what we expect it to happen. It means that there's no injury, no complications, no adverse reactions. And it should be, when they take that medication, it should be the desired effect. So a therapeutic response would be, I had a headache, I took a Tylenol, my headache went away. That is therapeutic. It didn't affect me, it didn't make me dizzy, it didn't make me nauseous. I took the medication the way it said to take it on the back, and my headache went away. So that would be a therapeutic response. Medication can be administered intended and sometimes for non-clinical purposes. So, an example, epinephrine. Someone's having they may need a repeated dose. So an example is epinephrine. Epinephrine is given for an allergic reaction. Sometimes we have to repeat that dose, even though we give them the epinephrine and the symptoms of the allergic reaction decrease and they start to do better, sometimes in about a 30-minute window or a little longer, 30 minutes to an hour, those effects will come back. So we may have to repeat that and give it again, which is why if someone's having an allergic reaction, even if they're taking their EpiPen, they do need to go to the emergency room, because they can have, if they only have one, they could have a flare-up within a 15 to 30-minute window, or even a little longer, sometimes an hour. Adverse medication effects, that would be things that happen that are not desired. So, and they cause harm or discomfort to the patient. We have to, and this is where those adverse effects, we have to think about the patient's condition. We have to think about, does this patient, if I give this patient Lasix or furosemide, this diuretic, 40 milligrams every day, are they going to be able to take in enough nutrition to replace that potassium? If not, their potassium level can get to the point that it is so low it can cause a heart attack or muscle spasms. So that would be an adverse reaction to an adverse effect of a medication, that it caused something that was unwanted. And it can be something very mild, like a muscle cramp, or like I said, it can be as harmful as and severe as a heart attack. Sometimes we give people medication because the side effect or the adverse effect is what we want. An example of that is Phenergan. Phenergan is given for nausea and vomiting, but a side effect of that is it slows down, or it relaxes helps relax the muscles. In combination with codeine, it can relax the muscles in the bronchus, and so the Phenergan with codeine, when they're given together, the adverse effect is it makes them sleepy, but it also prevents the nausea from the codeine, which will cause cough to decrease. So that's an adverse reaction that's not necessarily bad, but we utilize it in combination so that it has increased effects. There's a therapeutic index, and this is something we have to think about when medications are being given. So the median lethal dose is the dose that causes death in 50% of animals that are tested. So understand what therapeutic index is. The median is 50% of in animal testing it caused death. That would be the maximum dose. The median toxic dose, so that's the lethal dose causes death. The toxic dose causes adverse reaction. And then you have a median effective dose. So therapeutic index is based on the median effective dose is what we want you to take so that you get the therapeutic response. The toxic level would be the maximum dose plus however many more milligrams that caused adverse reaction. And then the lethal dose actually causes death. The relationship between the medium effect dose and the lethal dose, there's usually a large difference, and it depends on it's about the medication safety. There are some that are there's a very small window. So like a larger difference example for a toxic dose or a lethal dose, aspirin. We can take 325, we can take 700, we can take 650 milligrams of aspirin 4 times a day, and it's absolutely fine. But if I took all of that at once, if I took 4 grams of aspirin all at once, my liver might not be able to handle that, and so I could have a toxic effect. And it could have a lethal effect, and it could start to shut down my systems. Now, things like lithium has a very narrow window for toxicity and for it to be a lethal dose. It's a heavy metal. Our body can only process very small amounts, and although lithium is very effective for some forms of bipolar depression, there's a very narrow window of margin for error that can cause someone to die from the effects. Immune mediated responses. So that is when we are genetically predisposed to have an initial exposure to sensitivity or to an allergen. So that would be allergy shots. Sometimes people are so allergic to something that they will give them very small doses of it once a week and then once a month, and then they'll build up their ability to handle it. Medication sensitivity can occur, and so they can do that to allergens. But with medications, know that I can take penicillin today, and I'll be fine and not alert and not have any reaction. But the next time I take penicillin, I can have an allergic reaction. So just because someone's not allergic to a medication today doesn't mean the next time it's prescribed, they will not have an allergic reaction. So we have to be sure that if a patient says, well, when I took penicillin the last time, I got a rash, we want to make sure that the doctor's aware of that so he potentially won't prescribe it, because the next time it may be an anaphylactic reaction. We have to be sure that any kind of reaction to a medication, when someone says they're allergic, you want to ask, what kind of reaction do you have? If they say anaphylactic, you definitely don't give it. If it's, and you write anaphylactic. If it's a rash, you put rash. If it's GI symptoms, you put GI symptoms. Lots of times GI symptoms, nausea and vomiting, those are the first signs of an allergic reaction. So we have to be very aware and very careful with those kind of that kind of documentation. Also, there are medications that we give that the body builds a tolerance to. Pain medications are one of those. Anxiety medications, those controlled substances, those medications that were on the control list, those are medications that the body will build a tolerance to after a period of time, and they'll need more of that medication to get the same desired effect. So we have to understand that the body can do that. Also, if it has built a tolerance to it, then most likely if they completely stop taking it, they could have withdrawal symptoms. We also must be aware of that. Cross tolerances also can happen depending on the class of medication. So we just have to be aware of that as well. So I'm going to stop there for today. We will pick back up tomorrow with this. Remember that on Monday you will have a quiz over today and yesterday's lecture. So be sure that you're comfortable with the lecture. On Monday you'll have that quiz, and then you will have your first set of top 200 drugs test on next Friday. So everybody have a good day, and hope you have a great weekend, and we'll see you next week.